debate, I will invite Dr. Dipankar Das to speak on anterior uveitis clinical spectrum relevance to the general practitioner. Dr. Mayur, please come over. We can pull up another chair, Padma. You don't have to.
Respected chairpersons, ladies and gentlemen, at the outset, I'd like to thank AIOS, Dr. Shamashila, my mentor, Professor Biswas, and everyone here for this presentation. I do not have any financial interest in this presentation. This is purely an academic and case-based discussion. Now, out of all uveitis, anterior, intermediate, posterior, and pan-uveitis, anterior uveitis is the commonest. And you see, when you take history for an comprehensive ophthalmologist or an expert, the demography of the patient, the age, gender, from where the patient coming, ocular history, systemic history, treatment history, and other history are so important because 70% of your diagnosis is based on clinical history and meticulous clinical workup. Now we see these two conditions. One is a 6-year-old boy with a lacrimal gland swelling, and you can see joint involvement, a skin change, and a perihilar changes here. Perihilar changes here. So this was supposed to be a juvenile sarcoid. Later on, it was tested for Blau syndrome. Again, on the other hand, a young patient with an ankylosing changes and can present with a recurrent anterior uveitis, and it is usually in the middle-aged person. Now, out of 3 symptomology and signs, I have found 3 systems which is very, very important for uveitis. One is the skin. Okay, if you examine, take history of the skin as well as you examine, you get a clue for anterior and other uveitis. Second is the joint involvement. There is a seropositive arthritis, there is seronegative arthritis as ankylosing spondylitis I have shown. And third point is a cough, shortness of breath, and chest finding. These are very, very important. Now, certain important points is that always see the other eye or dilate your eyes when you examine the patient. For example, this is a herpes zoster ophthalmicus. We all can diagnose it instantaneously. But important thing is that you have to dilate the eyes and see the other eye for a lesion like acute retinal necrosis, which is very, very important. If you only treat the anterior uveitis, do not dilate the eye, you may miss an important point here. Now, setting of your room is very, very important. For example, I am showing you 2 pictures. One is a dilated room picture. Another is that the room light is off. You see in the B picture, the transillumination defect in VK is so prominent. So to see a flare, cells, transillumination defect, and keratic precipitate, you have to darken your room and to visualize the structure. Second important thing is that scleritis or sclerouveitis, where scenario is different. Here you have to say in daylight or a lighted room with, unlike the other condition of uveitis under slit lamp, and this is the different quadrant you have to demonstrate it. Now, pattern recognition in uveitis is very, very important. I have chosen a pattern recognition for keratic precipitates. Now, we know that keratic precipitates, the Arlt triangle is very, very important. Apart from Arlt triangle KPs, there may be diffuse KPs in some of the condition. Now, we see this first condition is a ankylosing spondylitis, seronegative arthritis with a small KPs here, where there's here you can see there are certain coin-shaped KPs. Coin-shaped KPs are usually for CMB anterior uveitis. And here you can see there's a diffuse KPs outside the Arlt triangle and there is no posterior synechia, mild posterior subcapsular cataract. So this is a constellation of finding for a Fuchs uveitis. Whereas this is again a uveitis, centrally located capiz, okay, and pressure is very high, 50 mm mercury. Pressure wakes and wanes. This is a what you call is a Posner-Schlossman syndrome or glaucometacyclitic crisis. Now, upper two capiz are sarcoid capiz, and this is a tuberculous capiz. Now you see this capiz, and you should immediately diagnose. Mid-dilated people, you see a tessellated fundus. So we are dealing with VKH. Now this is the capiz that I took photograph in my lab just 2 weeks before, where granulomatous capiz in sympathetic ophthalmia was visualized. Now see, this is again another capi under the black arrowhead. This is a crenated or a pigmented capiz, where we see in a chronic uveitis or basically in a resolved uveitis, which we do not treat. Now, GIA is very, very important because you have to differentiate between active and inactive diseases, and steroid-free management, as Dr. Meenakshi in our previous allergic, she had told that in children you have to be very, very careful putting steroids, and also in GIA, steroid-free management is very, very important. And early referral to the expert uveitis expert and the rheumatologist is a must in this situation. Now, this is again a 46-year-old male with a anterior uveitis, and patient was receiving adalimumab. So, certain drug history you have to take in your history, because this patient has a bilateral temporal disc pallor and the field showing a central defect. So, adalimumab can have a what you call a toxic optic just a optic neuropathy, and this can, you have to take history and you have to guide your, this is basically for expert, but you also have to aware. Always look for additional things and signs. For example, this is an anterior uveitis. Now this patient had a Wilson disease or hepatolenticular degeneration. So immediately, and on fundus examination, there's a temporal disc pallor, and immediately we have seen the Kesha-Fleischer ring. What is important is that if you do an anterior segment OCT, you can see what you call Kesha-Fleischer ring in the anterior segment OCT. You have to differentiate between infection, inflammation, and tumor. First case, again seen in just in March 2022 with a anterior uveitis, and there was a granuloma sitting. The UVM showed the granuloma itself. Now the Montu was positive. Chest CT showed evidence of prior tuberculosis. What is important is that this patient received ATT and steroid. Just after 4 days, there's a resolution of anterior uveitis, and by 14 days, the patient has complete her ATT, but suddenly she stopped the ATT for some complication. So this on to follow up, after 14 days, we have seen complete resolution of this active granuloma. Now, in inflammation, this is a 33-year-old female. Now we see there is an iris nodule with anterior uveitis, and this patient had cystoid macular edema, hyperemic disc, choroiditis, and choroidal granuloma in the right eye. And left eye also showed hyperemic disc, old choroidal lesion, and choroidal granuloma. So this is very important to dilate and see, and the chest CT showed perihilar as well as pulmonary infiltrates. Now, second scenario is that there is a in all tumors, you see, may not be because a uveitis. This is an 87-year-old lady with post-cancer breast 3 years back, post-chemo, post-pleural effusion, and there's an iris growth in the white light. What is important here is that the MRI showed there is an involvement of the lesion, and when the TAP was done, it was all hyperchromatic nuclei, suggesting a breast metastatic cases. Shortlist your differential diagnosis, tailor your investigation. This is very, very important. And rare cases you may anticipate. For example, this is a Dirophilaria worm which is published from the anterior chamber, and sometimes in chronic cases you can get ocular crystal in chronic uveitis. Now, newer uveitis entity, for example, tubulointestinal nephritis syndrome, you can get, okay, it usually present with anterior uveitis, sometime with the intermediate uveitis, seldom with posterior uveitis, where urinary beta microglobulin you have to find. Uveitis can be associated with glaucoma, such as Posner-Schlossman or Fuchs uveitis. Now, these are already I have shown you the clinical picture. Lens-induced uveitis, where AC cytology can be important. Everything is not uveitis. This is again a acute leukemia patient with a atypical hypopion, and you can see in the upper two picture the MRI showed involvement of the ciliary body region. After chemo and radiation, the lesion decreased along with the improvement of the uveitis. Now, we have seen unsuspected retinoblastoma, the diffuse retinoblastoma, in 2 hours of publication from Northeast India, where you see a few cases, around 2 to 3% cases of this retinoblastoma mimic as uveitis. Now, for treatment purpose, prednisolone, betamethasone, lotepred is good for when you are anticipating what you call glaucoma in this patient or ocular hypertension. Remember, prednisolone acetate is suspension form, and most important thing, you have to shake the bottle. Always right, shake the bottle before use because it is in suspension position. Now, this is very, very important slides. For dilating and cycloplegic, we can use topin to break the synechia. Once you break the synechia, you have to keep the pupil mobile, so you shift to homide or homatropin 2% eye drop. Almost you should not use cyclopentolate. Why? Because cyclopentolate, no, this is chemo-attractant. Neutrophil and other things get attracted and it worsens the uveitis. So this is very, very important situation. Now, in pattern of uveitis from Northeast India, we have seen initially when you published in 2005, the most important cases were idiopathic, followed by seronegative arthritis. And next, when you publish the changing pattern of uveitis, the HLA-B27 was most important. Now, 3 complications are very, very important for all uveitis. This I have taken from anterior uveitis, from DNB thesis, complicated cataract, secondary glaucoma, and cystoid macular edema. To conclude, anterior uveitis is the commonest type of uveitis. For all ophthalmologists, you have to differentiate between active and resolved uveitis in juvenile idiopathic arthritis. Each case can be special, and uveitis is a team effort. You have to include the other uveitis expert, you have to include the rheumatologist, you have to include pediatrician, etc. Thank you for patient hearing.
Thank you, Dr. Dipankar, for giving a very good overview of anterior uveitis. I want to emphasize one of the fact that the extremes of age, if you see anterior uveitis, you should be careful that you should not be missing muscular syndrome like leukemia, retinoblastoma, and metastatic tumors. Another important point is that if there is an uveitis, anterior uveitis with hypopion, and you are not able to see fundus at all, you look for that ultrasound and look for that whether you are missing an endogenous endophthalmitis, which, however, is rare. The history of immunocompromised status you should look for.